Good morning, everyone. It is a pleasure to be here. And in this Snap Talk session, we'll talk about complications in regional anesthesia and pain medicine. We have very well known and distinguished speaker in this panel, except myself. I'm hoping that we will have a great discussion on this topic. Before we start, some housekeeping stuff that all speakers will have 10 minutes to wrap up their presentation. Every 9 minutes, I have an alarm set up. I will remind you the time is up, and our goal is to give enough time for a Q&A session. I do not have any financial interest to disclose. We all know that procedural complications in interventional pain medicine and regional anesthesia are very rare. But when it happens, it can be catastrophic, including permanent development of permanent disability and death. Both of these specialties, interventional pain medicine and regional anesthesia, has been experiencing significant growth in the last few years. Thanks to the opioid epidemic, we think that this growth will continue to increase. It is important that we talk about complications and learn something from it. Following a complication, we should always ask, how can we prevent this in the future? We should take time to debrief and reflect on the event that transpired surrounding the case. After identifying the root cause of the event, we can strategize ways to make the necessary changes to prevent such complication from happening again. We all appreciate that in medicine, we must come to the terms that perfection does not exist. Medicine is an imperfect science. Complications are an inevitable part of medicine, as nicely said by Dr. Gawande in his book, Complications, a Surgeon's Notes on an Imperfect Science. Learning from the complications makes us a better physician, and it is an integral part of our sacred duty to continuously work to improve our skills in order to help our patients. Having said that, I will start presenting my case. My patient is an 80-year-old female with no significant past medical history. She has a history of major depression and she has been taking trazodone. She went to an interventional pain procedural suite for an epidural steroid injections for her chronic neck pain. Procedure went well per the procedure note I reviewed, but 30 minutes after the procedure, the patient developed weakness in the both legs along with the severe neck pain. Patient was transferred to the emergency department where she developed weakness in the both upper and lower extremities, including numbness and severe neck pain. In the emergency department, her conditions continued to be worsen. She developed bradycardia and hypotension, which required epinephrine infusion. CT scan done in the ED showed a hyperdense structure within the spinal canal, extending from cervical C2 to all the way to the thoracic T4 level, as you see from this picture. And here is the sagittal view. You see the hyperdense structure in the CT scan. The neurosurgeons of the local hospital suggested an MRI because of the rapid development of the symptoms, and CT scan is a poor sensitivity to diagnose cervical epidural hematoma. But patient was too unstable to have an MRI. Patient was on hypotension and she has been on epinephrine infusion. After several back and forth conversation with several hospitals, patient ultimately transferred to our hospital. Almost 8 hours later, she presented with the symptoms. She underwent decompression surgery in our hospital, where I was involved as an attending physician. And fortunately, she completely recovered from all neurological deficit. Simply put, a quadriplegic patient walked out of the hospital because decompression surgery was done within 12 hours, which we call it as a window of opportunity when to prevent permanent neurological deficit. This is the time is fine. What went wrong in this case? As I mentioned, that patient does not have significant past medical history, but she was on trazodone therapy. Trazodone, as you know, decreases this serotonin reuptake transporter in the platelet, which causes decreased platelet function and increase the risk of epidural hematoma. Patient was 80 years old. 80 years old associated with decreased platelet count and increased risk of epidural hematoma. The procedure was done under sedation, and although sedation is not directly related with the epidural hematoma formation, but because of her rapid development of symptoms, it is possible that some of her symptoms may be related to subdural penetration of the needle, subdural hematoma. Because procedural sedation decreases the ability to report paresthesia when we have approach subdurally, and increased risk of subdural puncture. How can we prevent this type of complication? SSRI like trazodone has been shown to have increased risk of bleeding in breast and orthopedic surgery. And this risk increases with advanced age, hepatic dysfunction, and concurrent use of aspirin and other antiplatelet medications. An American Society of Regional Anesthesia and Pain Medicine reviewed this evidence. They found that their recommendation is not to discontinue SSRI before a routine pain procedure because of the increased risk of uncontrolled depression, suicidal risk, and discontinuation of the syndrome. But they recommend to consider stopping before a high-risk procedure such as concurrent use of anticoagulant, elderly patients, and patients with severe hepatic dysfunction. So in this case, as you see, the patient was elderly, taking SSRI may be the most prudent step, safe step. Procedure was done under heavy sedation. Although sedation is not directly related to the epidural hematoma, sedation increases the risk of subdural formation of subdural puncture and subdural hematoma. And considering the patient's rapid development of symptom, it is possible that some of the symptoms come from the epidural hematoma. And here in this study, Dr. James Rathmel analyzed ASA closed claim database, and he showed that increased claim of the spinal cord injuries when compared to the claims without spinal cord injuries. 67% of the patients of the claims are associated with the spinal cord injuries after a cervical epidural steroid injection, compared to 19% patients who had no spinal cord injuries. Among the patients who had spinal cord injuries, 25% of the patients are almost non-responsive during the procedure, compared to only 5% patient who did not have any sedation. I will stop here. Thank you so much for your attention.